We will get started here. Thank you. The mic is on finally. Perfect. I'm Dr. Saw, and accompanying me here is Dr. Sorajja, and we have a whole panelist here for this live case from Scripps Clinic, which will be presented by Dr. Matt Price later. But we're going to start off with Maria, who is going to show us an AVI before we prompt and start with Scripps.
I just want to give credit to Chris Meduri and his team for the great result of the prior cases that they showed earlier. Oh, now it's gone. Oh my God, I'm so sorry. Basically what happened is they were able to place a 29 sapien 3 with 3 additional cc's of contrast, and they had 0 paravalvular leak after that. So wonderful picture, and once it goes through the disclosures, you'll be able to see it. I apologize, I thought I had it ready for you, and I wanted to save you the pain of seeing the disclosures.
Steve, the audio is dropping on and off. Okay.
Okay, here it is. I thought it's awesome. You see? 29 sapien 3, no paravalvular leak. So I think it was a great result, and I'm sorry that he is not here to tell you exactly what he did, but we thought it would be important to share with you. Thank you.
Mayra, was that the LVAD case?
Yes, this is the LVAD case.
LVAD case.
So for the ones who were not here earlier this morning, patient with prior LVAD who developed severe AI 6 months after LVAD and was treated with a 34 evolute art, and they had paravalvular leak. They post-dilated a couple of times with a 28 balloon. There was a lot of debate about going with a 30 balloon versus putting a balloon expandable valve. The decision was to move forward with a second valve, 29 sapien 3, with extra volume to be able to achieve a larger size. And they used the core valve as a landing zone to be able to place the balloon expandable valve. It was a very challenging procedure, but really an excellent result. Thanks.
Great. Thank you very much, Maria. So, Matt, we're ready for you. Before you start, I just want to introduce to you the panel. I'm Jackie Saw, Paul Suarez next to me. We have an excellent panelist here, and excuse me if I pronounce your last name wrong. We have Dr. Attizzani, Dr. Guerrero, Dr. Zajarias, Dr. Vannan, Malaisrie, Pershad, and Cavalcante. All right, you're on, Matt.
Hi, Jackie. Good afternoon. So thanks for joining us here at Scripps Clinic in La Jolla, California. We have a great case for you this afternoon of a left atrial appendage closure to start with, and then I have a second case to follow this, a nice case, a nice structural case. So first let me introduce the room, then I'll introduce the patient. So to my right here is my terrific second-year structural fellow, Dr. Praveen Panguluri, who's looking for a job. I'll vouch for him, so if you're looking for a partner, he's the guy you should hire. I'm here, my nurse here is Rahel, our circulator is Layla, my excellent tech here who's hiding now is Alex. We have on TE, we have Todd Hitchcock, and we have Dr. David Lerner, one of our interventional echo fellows. We have Bobby as a sonographer, and last but not least, Dr. Martin as our anesthesiologist. So let's talk about our patient. So this is an 89-year-old male who is a former veterinarian, typical sort of La Jolla population. This guy's 89 years old, but drives, or he used to drive until he lost his vision because of a retinal hemorrhage while on warfarin, which is the primary indication for the left atrial appendage closure this afternoon. His CHAS-VAS score is 4. His has-bled score is 3. Now, importantly, he bled from a retinal hemorrhage due to diabetic retinopathy on warfarin. And after that, began getting avastatin injections. He's now controlled. He's on maintenance therapy, Avastin, and we spoke with the ophthalmologist who felt that he was now safe to and can tolerate short-term oral anticoagulation. So that is the clinical story, sort of a typical indicated patient in the United States for Watchman left atrial appendage closure. So with that, let's go to our baseline TE images. David and Todd, why don't we walk through here? So let's go to echo. Thank you. That's just we're preparing our transeptal puncture. Let's first go to just the LAA view. So you can go to the left atrial appendage, say number 19 there, number 20. There we go, that's good. So this is our 45-degree view. In the 45-degree view, it usually looks like a windsock like this. Next one, please. There's our 90-degree view. A little bit of an S-turn. We look also at the 90-degree view and its relationship to the ventricle in terms of how posterior we should place a transeptal puncture. This is sort of your average left atrial appendage so far. Next one. This is the 135. What's nice about the 135 here is you see we do have some anterior depth. Usually the 135 gives you the shallowest depth. Here we have some pretty good anterior depth. You see on the right of the screen, that's where the aorta is, so that's anterior. And then the next one, here's our 0 degrees, which often will give you the biggest dimensions. We don't have the actual measurements recorded here, I see, but we got a max dimension of 19.5 millimeters with a maximum depth of about 28 or 30, I believe. So, well, here they are. So here's our measurements. Here on the 45 degree, you have about 16 by 26. Here on the 90 degree, you have about 20 by 22 next. So 19.5, excuse me. Here on the 135, you have 16.5 by 20. And finally on the 0, you have 16.8 by 25. So, Jackie, I apologize. I did not get a CT scan on this patient. Please forgive me. I don't routinely do CT scans.
Shame on you, Matt.
I can take it. So my plan, at least, my default is my minimum device size is going to be a 24 millimeter Watchman device. You want at least 10 to 20% compression. Our device sizes are 21, 24, 27, 30, and 33. So let's just say our maximum diameter is 19.5. 21 will be too small because you won't have enough compression. So I'm thinking at a minimum 24. And when we get in there, if I have a lot of depth, and it looks larger on angiography, I can consider it 27. Any thoughts on that, Jackie? Or I think I heard Ashish was on the panel up there.
Perfect.
Any thoughts about my plan?
Yeah, that's what I was going to ask the panel here. So what you've shown us so far, you have
And
somewhat
Jackie,
like
you're
a
breaking
cactus.
up,
Can you
so
hear
I
me?
can't-
Sorry, apologize. Let me
No,
just repeat
it comes
that.
and goes.
So you have a cactus-like shaped appendage. We can see that in the 135 view. You have a nice superior angulation tip, for a double curved sheath, it seems. The measurements you have, I think the maximum you had was a 20 by 26 depth maximum. So you said 24. Let's just go along the panels here. Do you think a 24 would suffice,
Yeah, so-
or would somebody would go for 27, say?
I was going to ask, what's the left atrial pressure that you had there?
Sorry to interrupt, guys. I can really only hear about every third word. So I'm going to assume you completely agreed with me on that. And we're going to... And so why don't you guys... What I'll do is I'll begin, because we have another case to go. And we can, as we're doing this, we'll discuss sizing. So I'm using a Baylis transeptal needle here. This is a standard C0 curve. I just always use the C0, which is the equivalent to the BRK. And then often I will... shape it myself a little bit. This patient does seem to have a little bit bigger of a right atrium, so I'm going to put another little secondary band back, sort of where I would think the IVC RA junction would be, right about here. Put a little bend on that, like this. I already have a transeptal sheath, a sort of an SL1 shape, a Baylis, I think it's a 45, I can't even remember, 45 sheath in the SVC. I also, if you want to look at the groin here, you see I have a 16 French sheath. So this is something I do routinely now. Although you could directly use the Watchman delivery sheath, I use a 16 French sheath with a single perclose. That way I can get ACTs, I have a bailout large bore access, and I don't get any issues with resistance in the skin when I want to rotate my delivery sheath. We already gave 7,000 of heparin, and after 5,000, the ACT was about 208, so we gave another 2,000 more. So we're fully anticoagulated prior to our transeptal puncture. So I put my curve on my sheath, I'm gonna put my needle, I'm gonna put it in the dilator. We'll now do the transeptal puncture. So what I'd ask is, Steve, if you can show both the echo and the fluoro, and I'll let you guys discuss device sizing here.
Perfect. Sorry,
Please.
Matt, can you hear us okay now? Can you hear every single word? Oh, it's still breaking up. Is the issue resolved for you? Can you hear us okay? Okay, well, in the meantime, it doesn't sound like you can hear us. Perhaps,
Yeah, I can kind of hear you, but not. So if I interrupt you, Jackie, it's not because I'm being rude, it's because I only hear silence occasionally, so.
All right. So one of the question here that was posed was the left atrial pressure, which that will make a difference as to the sizing.
Yes.
And so if you have that available, just let us know. Now, raise your hands. Who would think about going as big as possible, 27, and who would go 24?
Let's go
Who's,
LAO
who's
here.
selecting a 24? Let's say the LA pressure is 12. The majority. So the majority is going
Yeah.
for a 24.
It depends on the left atrial pressure, doesn't it? I mean, it's an important parameter that we should not overlook, before the device choice.
Yeah, absolutely. I think that's a good point. And the
So
other thing, before I open
There,
the
sorry,
device,
Jackie, just to interrupt there. You saw me on fluoro. I fell down on, I'm in an LAO projection here. I'm now posterior and mid, I would say. Which actually isn't so bad for this particular appendage. Anybody strongly oppose me crossing here? Should I come a little more inferior? I think I will.
that looks
No,
pretty
looks
good. I
good.
think you're inferior enough. We're overlap on your left panel. We can't see if you're facing posterior enough. Thank you. That's great. So there you are. So you are posterior enough, and you're sort of low level or the mid. That is acceptable. Although if you go a little bit more inferior, that'll be preferable.
Well, I think I already crossed, actually. Let's buzz there just to see. Let's go ahead and cross there, guys. Buzz, somebody. There we go. Okay, so you saw the bubbles cross. I'm going to make sure I don't go in the posterior aspect of the LA. I actually counterclocked a bit. I'm fixing my needle and advancing my dilator sheath over the needle.
So
Like
Matt,
that.
do you typically use the RF needle or do you use the BRK1?
I almost exclusively now use the the Bayless. It's just easier. I just find that it's consistent. I don't struggle with crossing. You want to make these, if you're doing 4 or 5 watchmans in a day, you want to just move things along. You don't want to struggle with having to use back of a coronary wire or use a Bovie, I guess. But this is just so clean and nice. And also, another thing I'm working with is a actual steerable needle where we can adjust the curve while you're in the body. It's really quite nice. It's made by Indian Wells. I've been using that intermittently, although it's not really widely available as of yet. So what I also use routinely now is this ProTrack wire, which is also by Bayless.
Matt, this is Joao Cavalcante from Pittsburgh. Can you hear us?
Let's go straight AP for me, please. There we go.
We're
Okay.
trying to
About
resolve
the left
the
atrial
issue.
pressure, because now he should be able to at least.
Yes. Can you tell us the left atrial pressure now? You should have that.
I just looked up and I saw that I had the waveform, but I didn't measure the pressure. But I'll give you that. Don't worry. What I'm going to do is, once I get the watchman sheath up, we'll get left atrial pressure, okay? Do not worry. I will provide you that. So you just saw me cross there on the fluoro. I felt the sheath cross. So now I will walk this out. I've now dilated up the septum. So another thing is, we used to traditionally, put a stiff wire in the pulmonary vein, the left upper pulmonary vein, and then advance our delivery sheath over that, both with most left atrial procedures like MitraClip or LA closure. But I've moved for both MitraClip or valve and valve, whatever I'm doing, is to use really this wire up in the left atrium. It's quite nice, quite safe, quite supportive. Jackie, do you use this wire ever?
The ProTrack wire? Yeah, I
And,
love the ProTrack wire. I agree with you. Trying to simplify the procedure. If you want to cut it down, your scrubbing time to about 15 to 20 minutes, I think. I love the RF. I tend to choose the RF if the septum is a bit thick, if the septum is quite pliable, a lot of septal aneurysm, or if there's a PFO, and I really want to be very precise, I would definitely go for the RF. And I find that, a lot of times you're trying to get the stiff wire up to the left upper pulmonary vein, and I'm wasting 5 minutes doing that. ProTrack is perfect. It's 032 and it's pretty stiff, so getting any of the 14 French sheaths up there for LA closure is actually pretty straightforward. So I do love that. I have a question for you. So, number one, you didn't tell us LA pressure yet, but number two, what is your sheath that you're selecting?
I'm just using a standard double curve sheath. I'll tell you that I use this 80% of the time. If there's a single posteriorly directed lobe, oh, careful. Okay.
Jackie. Just
Sorry,
one
we had a
question.
little issue with our drape here. If I have a single posteriorly directed lobe, I will use a single curve. I hardly ever use an anterior curve, only when I really think I need to get better anterior direction. I say probably 5 to 10% of the time I use an anterior curve.
We have a question
I'd say
from the
15%
panel.
of the time I use a single curve, the rest a double curve. So I'm just getting my transseptal sheath here. I'm in a straight AP projection. If you look at my delivery sheath, the side port is at 3 o'clock, so the natural curve across the interatrial septum. And I'm holding this wire here, and if you just go to the interatrial septum and watch me cross here, that'd be great. You gotta find me, I think I'm a little more posterior than that. So I'm across, it feels good.
Can we have the fluoro
Way
image
back there,
larger
exactly.
than the TEE image?
And we need TE in the corner, and we need fluoro big, Steve, please.
So we have a
Great,
question from the
perfect.
panel in the meantime.
Now, going back to the sizing, the discussion of the utilization of CTA. So what to look for in the CTA and how often it changes your management? How much the CTA guides you for the LA closure? Could you elaborate a little bit on that for the audience, please?
Yeah, I think that's a good question. How many on the panel routinely does CT before an LA closure? Raise of hands. Me too. So this is great. This is
How many
almost
said
more than
yes? I didn't
half,
hear that.
actually. I'd love seeing this transition. And I'm a pro CT person, and I think the CT really gives us a more accurate understanding of the anatomy. I think it's unparalleled compared to TEE for the challenging anatomy. So you can tell the direction of the chicken wing bend, the depth of where the angulation is, and where the trabeculations are, and where the lobes bifurcate, and actually even more accurate sizing. So I think in all these aspects, CT is superior to TEE. So I routinely do CT, and I've been burned a few times in the past without doing CT where we had to abandon procedure because the echocardiographer couldn't visualize these challenging anatomies. So that's why I changed practice. What do you think, Maria?
So at my prior institution at Evanston, Ted has been doing a lot of this with mostly TEE. I think it depends on what you're used to. I voted to get CT implemented in the workflow because I would feel a lot more comfortable about the sizing. As we were discussing earlier, the 21 may be too small, but also the TE measurements may be a little bit underestimated in general across the TAVR world, the mitral world, and now the left atrial appendage world. When you compare measurements CT and TEE, there may be a little bit of underestimation of the size in TEE, and that's why it's so important to know the left atrial pressure.
I almost just took off the kneecaps of my Echo fellow. That was, sorry guys. Again, I sort of heard it back and forth. I apologize if I'm interrupting. But if we go to hemos, can you guys get hemos? So what I basically do, I just have a routine, So just to move things along, I put up my delivery sheath. You saw me, I wasn't talking, but I used, to advance my pigtail, 6 French straight pigtail, through the delivery sheath, I used the stiff end of an 035 wire, okay? Just so it goes in easier. And then pulled that wire back. We now have a pigtail up in the left atrial body, and we hooked it up to the manifold, and this is our LA pressure. So, and if I wanted to give fluids, I could. Our mean pressure is 12, so that should be fine.
So the panel is happy. We're happy with the measurements,
Yay.
and if you can make sure you have the final measurements, that is the maximum of 20, I think most of us will be happy with
We've been
the
working a little
24.
bit on
Although
I did a case
I'm
of the
not
day
committed
with
myself yet. I would like to see the angiogram first before I open the device.
It's actually kind of neat. We'll see where that goes. But first, let me just show you. I'm in the REO caudal projection. I'm gonna advance my pigtail up into the left atrium. Excuse me, the LAA. There it is. Why don't you just give me a test there, sir? Our creatinine is normal, so we do a nice picture here. Ready? There you go, okay? So ironically, I think a single curve would have worked in this case as well.
Is that a 20/20 areocaudal 20?
This is a 30, almost a 30/30, 29 REO, 24 caudal.
Right.
Close enough.
I'm gonna say
kinda go
just
up
on
here.
that first look alone,
Advance my.
I'm going to ask the panel, does this change your decision about size?
We should measure again there.
I'll get some more pictures to you guys. We'll go a little more caudal.
When I
Look at your
typically do the
deployment
sizing,
view from CT
when I
scan.
typically do the
It
angiogram.
confirms something that I was thinking before going in. Test there.
Hey, Matt, yeah.
Good. So I'm just going a little bit. What I'm going to do now is I'm going to see if I flip my pig around, if I can get that here. But I'm going to ask David,
Yeah, the 135.
the echo fellow, if you can show me the 135 exactly. I want to get to that more anterior lobe. Test there, please.
Posterior.
You're trying to get to the more superior lobe there with the distal tip of the sheath. And that's one of my comment was, I like to go as big as possible, but I think here we might be challenged with the amount of depth that we're seeing and where we can place the tip of the sheath. So I'm now trending to more agree that 24 probably would suffice. Matt, would you agree with that comment?
Yeah, 24 for sure. So for sure. And you can say here also that, well, geez, I mean, Do we even have the depth for a 24? And I'm going to talk about traditionally what we do and what I'm going to do today. So what we'll do is I'll do a cine here so they can see what I'm talking about. Let me just test there for me, please. So, I'm pretty close to being where I need to be. Ready, cine? Good. So this is actually a really good example, is that we have, for those of you unfamiliar with Watchman implantation, you have the delivery sheath. There are 3 proximal markers that delineate where, all things being equal, if I did not move my sheath now, where the different size devices' shoulders would land proximally. So the lines there are 21, 27, 33. So a 24 device, if I deployed in a straightforward traditional fashion, my 24 millimeter device shoulders would land pretty far back into the left atrium, right? So I'm going to have to sort of maneuver a little bit deeper. I think I'll go a little, actually more in the center of the left atrial appendage. And I'm going to be very careful to make sure that I do not lose any ground by some counter pressure with my right hand as I deploy this. So, and I haven't done my final sheath positioning yet because there's no reason to. I know I need to use a 24, and I don't have the depth for a 27. So what I'm going to do now is just set up my 24 while I have my pigtail in there and everything's nice and hunky-dory. So
Perfect.
What Alex has already done is align the markers. Have a white, yeah, let me borrow this real quick, thanks. The feet of this device, we zoom up real good, guys. Steve, thank you, awesome. So let's advance the feet just a little bit. Tap it forward just a hair, a little more, stop there, and come back.
Are you planning
Come back a hair.
to extend it out or cheat the feet a little bit, or just right in line with the marker?
Right in line. Come back a little bit more, Alex. A little bit more. Sorry, sometimes it jumps. Right there, that's fine. Good. So now do their flush and everything. So I don't cheat the feet anymore. What I'm going to do is just make sure when I deploy this is that I really do not lose any ground at all. And we'll see. It may fall back. Hopefully it won't. So they're just checking, do sort of a first round flush, make sure there's no bubbles. And now I'm going to get my final sheath position. So Praveen, I'm going to have to ask you
All
to
right.
test.
While you're advancing up there, maybe I can ask the panel, do you normally use a double curve, or would you think about using a single curve as your start-off sheath or your workhorse sheath?
No, I pretty much use the double curve 90% of the time, unless there's a CT indication that would tell me up front that might be better off using a single. But
Okay. Anybody here use a single curve as their workhorse? Saibal is not
Other
a panel,
than
so we don't
Saibal,
have
other than Saibal is the only
He's about the only person that I know who routinely uses a single.
I'm going to explore this appendage a little bit to see if there's a deeper spot. Test
Fair
that, please.
enough, yeah. So for me, if I see an appendage that's pointing downwards, I would select a single curve sheet, but I think the workhorse for me is also a double curve. So walk us through, Matt.
Well, yeah, I'm just exploring this appendage a little bit, probing. See if there's maybe another spot where I can get a little bit deeper. But it's actually pretty small up there.
yeah,
Nope,
but Matt,
that's not it, right? Test there?
you could ride that pigtail with that sheath a little bit. I think you have a couple of extra millimeters, and that'll be enough for your 24.
Yeah, if you look at the echo, he has, instead of my hands, put the echo up there, yeah, is that you see the marker, the pigtail is in that deep.
I assume this
I
is
call
a
it anterior,
six
you call it superior,
French
but test.
pigtail, right, Matt? Is this
Yep,
a six French?
Test.
Yeah, sometimes,
Test.
if the trabeculation is distally or the lobe is small, I might use a 5 French just to enable you to get it a little bit deeper if you need to get your sheath deeper. But I think you have enough perches there to get your sheath up more for sure.
Test there, please. Good. So we're going to take that, okay? So,
Right.
yeah, you know what? Whenever I've gone to a smaller pigtail, I've always gotten myself in trouble. So I'm going to just stay right here. What I'm going to do, I'm going to keep this because I'm nice and deep where I want to be. And I'm going to ask Praveen here just to unscrew the manifold. Just put a syringe on the back. Don't aspirate. Give that to Sasha. He's going to flush, do a final flush. So this is what I do. So I keep the pigtail in again to the last moment. So go ahead and hook that up, guys.
Do you use apnea, or you tend to skip that part?
Flush, flush, flush. What part do you tend to skip?
No, he's asking if you have your anesthesiologist hold the breath as you bring your catheter device up.
Exactly. So right now, I still have my pigtail there.
Yeah.
So it looks great. So now what I'm going to say to Dr. Martin, Doc Martin, can you hold respirations, please?
Perfect.
Good, so respirations are held. I'm gonna pull my pigtail back. You're gonna hand that to me. We're gonna go meniscus to meniscus. And I just want you to follow with contrast. Do not aspirate. Just 2 or 3 syringes, Praveen. I'm keeping that counterclock rotation. I'm gonna wait till my marker's on up. There, good. See, I lost some ground, but I'm gonna make it up by counterclocking, I believe. And this is actually straightening out. See how it straightens out the sheath? Test there. It's funny, there's a couple little lobes back there.
That's a good starting point.
So I'm gonna withdraw my sheath, maintaining the distal aspect stable. Test there for me. Good. So I'm actually in the back of that little sheath, that little lobe there. It looks like there's more room, but in that lobe there's not. So if this doesn't work, I have to go into that other lobe. I'm now gonna deploy this. Test, please. Thank you, that's good. I go real slow. I'm maintaining my counterclock with some counter pressure on my right hand, and breathe, please.
Excellent. Yeah, I like this approach of really slow deployment. I think that really helps in terms of preventing the device from jumping
So now you're
proximally.
gonna aspirate. So
One of my EP colleagues waits there before the deploys to wait for the device to warm up. And he showed me that trick. I think it may help to avoid this jumping.
At what
let's
point
flip
does he
the echo
wait?
on the fluoro, please.
Maria, what point does he wait till? Halfway deployed before he extends more, or?
Correct.
Yeah, okay.
So I want the echo big, the fluoro small, just so you can see where we're at. So what I did there, I really changed the way I've done this since I began doing Watchmans. Is before I'd really keep my right hand on the core wire or the core bar and withdraw the sheath. But now I really give counter pressure on my right hand. I'm not pushing it forward, but I'm just really making sure that that distal end does not move. And you see, first of all, we have really, just on fluoro, we have excellent compressions. And then on echo, we're landing exactly where we want it to be on the, so we'll go through this now. Let's just go, this is the 90 here, looks great. We haven't done the tug test yet, which I'll do in a moment. Let's go to 135, let's go to 135, let's look at that. That's always the key one, really. We have nice depth of the device, you see that? That's just great, look at that 135. So I think now that we've warmed it up a little bit, I'm gonna do a tug test. So what I do there is I open up the TUI, I withdraw the sheath, okay? And I also sometimes just look at my device, and I can see the actual core wire here spinning back and forth, the torque of the heart, the torsion of the heart, which is always a good sign, meaning you have good compression. So then I'm gonna just cine, and I'll just slowly try to withdraw this, and I do it a couple of times like that, and it pops back into place. So it maybe gave a millimeter or two when that first withdrawal for the first tug as the tines engage with the trabeculae. So you have to aspirate again, and we'll do some injections.
Can you take
So
a
what we'll do is
Yeah.
I'll do an injection, and then we'll go through an echo, looking at color and compressions. Take your time, you're doing fine. So I think it looks good by 135. Don't you think you want to color that for me?
Maybe I'll
Bobby?
ask the panel, what do you guys think about the position at this point? Are you
I
happy?
think it's perfect.
It's very good. And going back to the discussion about the sizing, I think it depends on the
Okay, so
experience. I mean,
I'm
you
gonna fill
obviously
my
have a
catheter.
very experienced
We need some
operators
pictures.
there, very comfortable with the TE, and they have done everything, correctly. I don't have that experience,
Ready? Yep. That's saline, right?
One of the nice things about this device
Is it
too
fine?
is even if you choose one size larger and have greater degree of compression, it's relatively forgiving. And one clear thing we know is we don't want to undersize
Let's
for
do this
sure.
again, okay? I'm gonna
But
pull
if
this
you
back.
oversize a little bit more, there probably is not a lot of penalty. Would you agree with that, Matt?
I honestly only heard about half, but I think he said we want to oversize. I'll accept oversizing because I really do not want undersizing. So if my maximum compression is 8%, I really don't. I mean, I don't want it. I don't feel good with only an 8% compression, although that is on label. I've released 8% because that's all we could get. But if I can get a solid 15, 20, 25, I like that. You see here, this is my angiogram. I think all that contrast is going around the device. There may be a little bit of a a gully in the anterior portion, maybe just a hair, but we're never going to fully cover that. My shoulders are exactly where I want them to be in terms of the os of the left atrial appendage. Do you agree with me, Jackie?
I think it's through the fabric, Matt. I think you're okay.
Yeah, it's through the fabric. So what we're going to do quickly, although we're making good time, is they're just walking through, looking at color each angle, and then we can also measure compressions. I think this is going to be a great final result.
I agree. It's a beautiful result. Nice job.
Yeah. It looks great. The position looks fabulous. So I think if you pass the pass criteria, I think the whole panel will be happy to release this. Maybe I'll just ask the panel, we've been implanting this Gen 2.5 for, close to a decade, many years anyways. What do you think is the biggest change in terms of our practice now compared to years ago with this device? Matt sort of alluded to, we tend not to...
Yeah, I think oversizing. I think being a little more aggressive with our sizing.
Okay. And I do like the comment that
I would
you
also
made.
say the way that we deploy it, I think that, obviously we're very concerned about procedural complications. We want to avoid tamponade and pericardial effusions at all costs. And I think that, I would even say in the PREVAIL trial, we were so cognizant of procedural complications that we not that we left things that maybe we could have done better, but I think now that we understand the procedure more, we can get a little bit more aggressive in terms of sizing, in terms of deployment. I think that a lot will change as well when we have the next generation Watchman device, the Flex device, as well as hopefully we'll have more devices available in the U.S. market with the Amulet trial. Hopefully coming to a close in the coming months. We'll need, 2-year follow-up, is that right, Jackie? You're involved in that trial?
Yeah. The Amulet ID I think it's almost completed enrollment. I think it's a few more months away. We look forward to that trial data. But I think one of the major changes, I think early on in our experience of Watchman, a lot of implanters are placing the device really quite deep. So now, and there's a fear of thrombus formation on the surface of the device, on the atrial side, and so I think moving towards more proximal deployment, especially if you're, for instance, what you have here flush against the orifice, that's a perfect,
okay, guys,
perfect
Jackie, again, I
position.
apologize if I'm interrupting because it's down to one word out of every 5 now. So let's talk about this. So first of all, let's talk about the pass criteria. So position, we like our position. We're at the os. We have no uncovered lobes by echo or angiography. The Tug Test was really nice. I'm happy with our anchor. Our compressions are 18 to 22%. So that's just right. That's gravy right there. That's in the zone we really like. We have solid compressions. You never, if any compression does not meet 8%, do not leave the device in there. I think one thing I was talking about how we can be maybe a little more aggressive now, but we can't have a result where you have a residual leak or an embolization, so really make sure that all your compressions are good in every angle. And we clearly have a seal by fluoro and by echocardiography. So I'm going to release this device unless the panelists have any argument with that. I don't think you guys do.
No,
I'm
everyone
going to be
agrees.
able to hear you anyway.
Looks great.
So I'm going to just counterclock the core wire. And you can actually flip this. Make the fluoro bigger and the echo smaller if you don't mind. On the screen, Steve. And there we're released. Steve, if you can make the fluoro big and the echo small, that'd be terrific. Let's aspirate, because we do a final shot. There we go. Okay, so fill there for me. I'll take a slightly different angle, maybe take the parallax out a little. Move this back a hair. Ready? That's just perfect, I have to say.
That looks great. Wonderful. Matt's beautiful results.
So the catheter is now out of the body, actually. So now I just have the 16 French sheath. Praveen is going to take care of this. We have one pre-close there for the 16 French that usually works. We can always use a figure-of-8 stitch if there's some oozing. I don't like to reverse the heparin generally for these patients, but if we have to because of oozing, we will. You can see the residual ASD there. It looks good. We'll do a final check for an effusion. What I also like to have the sonographer Bobby will do is before the patient leaves the room, just take a transthoracic probe and do a couple of shots so that I get a routine echo in the morning, and we'll have something to refer to. For example, there's a fat pad or something like that.
Matt,
So, yes.
if you can hear us, perhaps you can tell us what your anti-thrombotic strategy would be post, and also your repeat imaging post or surveillance with TEE. When would you
Right.
do that?
All right, so imaging post, I bring him back at 6 weeks and at 1 year. That's pretty straightforward. This patient actually agreed to be in a clinical study I'm doing. It's a single center study, which is edoxaban monotherapy after Watchman implantation. So the hypothesis being is that it's as safe as the combination of warfarin and a baby aspirin, as effective, but perhaps safer in terms of less bleeding complications. There's some data out of Europe, off-label obviously, that NOAC, both with aspirin and without aspirin, appears to be effective in terms of device-related thrombus. So he's in a clinical trial. If as long as there's no complications of the procedure, his echo looks good tomorrow morning, he'll receive edoxaban for 6 weeks when we bring him back. If everything looks fine, we'll then transition him to aspirin and Plavix. So that's what I do for him, because I thought he was a good candidate for that. For patients who are truly oral anticoagulant contraindicated, I'm enrolling those patients in the ASAP-2 trial, which Jackie is the co-principal investigator of. So you can maybe comment on that. What I'm going to do, though, because I have a case next door, is maybe give me about 60 seconds to walk next door and get an update in that room, and then you'll come back to me?
Okay, perfect. We will have the discussion while you move to the next room. Thank you, Matt. Beautiful case.
Thank you. Hey, Praveen. Hey, thank you, guys. Thank you very much, guys.
So Jackie, what is the standard of DAPT for Watchman? Where are we at?
So it depends on, again, it depends on the patient population that we're dealing with. So if a patient doesn't have absolute contraindication to anticoagulation, then we should probably follow the FDA recommendation, which is aspirin plus warfarin for 45 days, and then aspirin and clopidogrel out to 6 months, and then aspirin alone. But unfortunately, as you know, a lot of our patient population are not so clean cut, and they have a lot of different contraindications. So this anti-thrombotic strategy poses really highly variable. A lot of centers in Europe and around outside of the US, a lot of us use DAPT therapy. So if you look at proportion of patients being treated on DAPT, that's probably the most favorite therapy. And but there's a question about, well, should DAPT therapy be 1 month, 3 months, 6 months? That's really up in the air. The original ASEPS registry used 6 months of DAPT, which most of us feel, well, that's really too long to expose the patient to the risk of bleeding. So in the ASEP-2 randomized trial of 888 patients, together with the FDA, and we selected a 3-month strategy of DAPT, so aspirin and clopidogrel. And then you have all the other operators who think maybe, NOAC is good enough. And we don't know, is it full dose NOAC, low dose NOAC? Is it NOAC with aspirin or NOAC alone? So there is a lot of controversies about that, and there's no, answers for that at this point.
So is the ASAP-2, where is it at in enrollment right now?
That's a very good question. We started enrolling ASAP-2 about a year and 3-4 months ago now. So the plan is we wanted to enroll 888 patients. Enrollment is slow because, as you can imagine, in the US, a lot of patients are already getting Watchman, even though they have relative contraindications. So there's some off-label use for sure. And around the world, a lot of patients who have OAC contraindication were already previously treated with device. So now you're saying, well, you're not getting a device, you have a 2-to-1 chance to get device versus aspirin alone. So it's challenging to enroll globally. So we've expanded a number of sites to about 100 global sites. We are about, the last I hear, close to 20% enrollment. We still think, yes, enrollment is slow, but we're going to be on track to get to 888 patients, hopefully over the next, couple of years or so. The results will be a long ways away, though. Maria, you have a question?
What's the latest with the lariat? What happened to it?
That's a very good point, and I think a lot of experience previous to Watchman approval was with lariat because in the U.S. you don't have any other option. But currently there's the AMAZE study that's still enrolling patients. But remember that AMAZE study is not really looking at the endpoint of just stroke prevention. It's actually comparing patients who might need ablation. As well, so I'm not so sure how that's going to change our practice in endovascular LA closure. The preference would be still endovascular versus epicardial if you can avoid epicardial, I think, for simplicity of device implant. So, is Matt in the other room already? Is that Matt? Oh, wow, you're fast. Did you scrub? Did you unscrub? And that was fast. All right, are you ready for us, Matt? Can you hear us?
Can you see me?
We can see you.
We're having a little technical difficulty, of course, but I can talk about the case. Our ice was working perfectly until I walked into the room, and now we can't see it anymore. But why don't we do this? Why don't we talk about the case, and then we'll slowly begin, and hopefully our ice will be working by then. Let me introduce Ray Foley here, my other second. Well, I have three of them. This is my second-year fellow. That's right. And what's up? Good. We have ice imaging. Good. So, and why don't we pull up the slides too? Would be great. This is Ray Foley, second-year structural fellow, interventional cardiologist, looking for a job.
That's right.
Yes, okay.
Exactly.
And it's like Sophie's choice. Praveen is really good too, so is Ray from next. So I wouldn't choose between you two. Let's see who's in the room here. I have Patrick back here as my tech who's scrubbing in now after fixing the ice with Stephen. Thank you. 5,000 of heparin, please. Hi, sir. And we have Paula, our nurse here, is going to give the heparin right now. And I have Lexi, who's our circulator. Okay, so slides are ready. Let's pull them up. So listen, I know we do a lot of mitral, LA. I thought I'd go old school, traditional structural heart disease. I did a wonderful mitral clip this morning. It was really funny with an XDR,
right,
two
yeah.
XDRs, and an A3 flail prolapse, and I was laughing that I should have done that this afternoon. But we're going to go old school here. This is a 71-year-old male with several months of progressive exercise intolerance. He has fatigue and dyspnea while walking, particularly up the hills. He does have a history of coronary artery disease. And a recent echo showed normal LV function, but his RV was dilated, and he had modest pulmonary hypertension with a systolic pressure in the mid-50s. He had a hypermobile interatrial septum. We did a TEE, which we're going to show you right now. Next slide. So hopefully those project well for you guys. So you see on the left side of the screen, there is a Austin secundum atrial septal defect with a quite mobile interatrial septum. There is a pretty much deficient retroaortic rim. I mean, you can cross your eyes, maybe there's a 1 millimeter rim, but there's in other angles, there was no such rim. So there's a good posterior superior rim, but there's a deficient retroaortic rim. You see the bicaval view on your right. There is a good SVC rim, a good IBC rim, but a very floppy septum, which complicates matters, which I thought would be a nice live case. Next slide. So here's the 3D reconstructions. You see here we have this oriented in to the pathologist view. So you see the aortic valve on the sort of upper right of the screen. You see this central oval Austin secundum ASD. You see here very nicely on 3D the deficient retroaortic rim. And then I always do 3D reconstructions on all of my ASDs. And I can't read the writing from here, but the maximum defect diameter was about 16.8 millimeters, right?
Yep.
And that was sort of confirmed on transthoracic. All right, that's the presentation. Jackie, what do you think about this? We've got time to have 45 minutes. We can chat.
I would just preface it by saying I showed precisely a very similar case just before lunch. And I won't scare you, but it had to involve a snare after that. So, but this won't be your case, though. I'm sure you'll do a better job than I did.
Well, you're setting expectations very low, so thank you very much.
All right, but so you're measuring about 17. This is obviously, missing the retroaortic rim is always concerning, but you do have rims everywhere else. And I assume you're going for the M-Platz septal occluder.
Correct. Let's put up ice while we talk here, guys.
No heparin
All
yet.
right.
I get 5,000.
Oh, you did? Okay.
And are you thinking of using any interesting advanced tips for this or tricks to do this? Or are you just going to deploy this, simple, straight old traditional way?
Well, I thought I would do it traditional first, but in my back pocket, I am ready for some tricks. So I'll tell you, I'll look at this. For the groin here, I like the 10 French ice personally. It's a little more robust for me, and I think the image is a little bit better. So I have a 11 French Terumo sheath for the 10 French ice. I have an 8 French sheath, which I'll upsize to my Amplatzer torque delivery sheath for whatever diameter size I need. And then on this side, I have a 5 French Venus line sheath, in case I need other catheters or tricks like a balloon to prop up the the left atrial disc. So so my plan is just to go in there and do it the traditional way, and if I have to, I'll do it differently.
Are you going to balloon size?
I can't hear you one more time, Jackie.
Maria's asking, are you going to do balloon sizing?
I was not planning on using balloon sizing. And this is, I really rarely balloon size now my ASDs. I have a good transesophageal echo.
That is a good point for discussion, for sure.
Yeah.
And so if you're not doing balloon sizing, then, how would you size this, especially when you have quite a floppy septum? What is your upsizing diameter, you think?
Yeah, well, let's look at our ice. So that was, that's what I was thinking about like last night and this morning when I was having my morning coffee. How are we going to do this? So I have a sizing balloon open, okay? So it's not that I'm saying that I will not do this, but
Can
this
I
might
take a
be one
poll?
case where
Can I
do
ask
this.
the panel? Who would do balloon sizing here? Well, we're kind of split. Well, maybe 60-40. Okay, but you do have a few folks on your side, though.
So let's
So,
go-
but can I
here's a
ask you,
question.
what
Record
would
that,
your
please.
sizing algorithm
Yeah.
be then, without balloon sizing?
And let's just, if you could just, Gary, if you could just pause it and measure that diameter for me, if you don't mind. So was that question addressed to me, Jackie?
No, it wasn't, to the panel.
So it was to me, Matt, it was to Ashish. So I was going to think about, so the maximum diameter you said was 16.8.
16.8.
Yeah, so I would go with a 20 millimeter ASD occluder.
All right, I'll take that into consideration. Any other thoughts?
And, any
What
other
is
thoughts?
the largest size that
I'm not going to say what I'm going to do until I hear all of you guys tell me.
What is the largest size that you would treat with a different device, with a Gore device?
Yeah, so I
The
mean,
Gore is
I think-
maximum 17, so I won't use the Gore.
I
Of course,
agree.
PFO.
Just for the sake of discussion, what would be the highest,
Right.
that you would treat?
Yeah, I think a Gore device, the Cardioform, terrific device. I actually, as a default, deficient aortic rims that are, I would say, smaller than 14 or 15 millimeters, I would use them. I think in this case, because of the floppy septum primum and the lack of a aortic rim, I just don't think that a 30 Cardioform would hold. So that's why I'm not using a Cardioform. Okay, good. You got 12 in that direction. Let's go live, please. Just fine. Just go live. Any other
we have
thoughts on sizing
we
here?
have a comment, you would go 3 above. Anybody else would go larger based upon, again, the lack
Pause
of
that,
the
please.
rim
Pause
and
that.
also the really floppy septum.
Okay, and roll the ball, roll the.
You would? So what would
roll
you
the
go for?
Dial a little.
If
The
you're
biggest.
not going to balloon sizing, what would you go for?
Go back. Right there.
So you go for a 21,
Measure
22
that, please.
without balloon size.
All right.
All right, Matt, what is your decision here?
Okay, so there's 17 was my size, okay? And then I add 4 for a deficient aortic rim, I'm at 21. And then that floppy septum really scares me.
21 is going
Because I think that it's not going to be very firm to hold the device. So then I want to add a couple for that. So it's either a 22 or a 24, okay? The key thing, obviously we don't want to oversize because that's related, that we believe
Yeah,
it's
I think
associated
your
with
guess is as good as
erosions.
mine.
So,
But should we actually?
Hold on, wait 1 second. I'm not done yet. I'm going to try. My thought was a 24, and I'll tell you, I'm going to put up the delivery sheath, and we're going to see how that septum primum behaves. How does that sound? So 26 is a really important number because at 26 is when the braid of the amplifier device gets thicker, and then in fact. I don't know if John Carroll's there or Paul, whether I think that erosions may be higher, riskier once you go bigger than 26 millimeters or more. So my thought is by default here, it's gonna be a 24, maybe a 22, but probably a 24. In part just because, go live please on ice, in part just what Jackie was saying before as well as.
So we know that if we were to do balloon sizing, I expect that we would stretch it out by, say, a couple of millimeters or so. Hey, Maria, do you agree with that? If we were to do balloon sizing, normally we would see perhaps a couple of millimeters larger, based on what we've seen in other studies as
So
well.
George,
when you
stop
do
that.
balloon sizing versus not,
And measure
the
that,
TE
please.
is usually about 2 millimeters larger when you do balloon sizing. And so let's say if I'm sort of if I'm 17 going to 19 and there's a floppy septum, I personally
Deficient
think
rim.
more like a 24.
That's fine, 24 then.
So you agree with the 24? I didn't hear that.
Maybe raise of hands, how many would say 24? We have 1, 2, 3, 4. And how many would say 22 or small?
I think a balloon
So about half and half.
The balloon size will be closer to 20, like 19, 20, and upsizing only 2 millimeter, with all this anatomy, the septum and all that, maybe too small, so I think 24 then.
I agree with you.
Yeah, that's what I'm
Especially
thinking,
given
Maya,
that I
24,
embolized one very
exactly.
similar to this, I'm tempted to go bigger for sure.
Okay, so I'm just trying to get my wire in the pulmonary vein. There it is. Guys, oh, I'm sorry. So fluoro. So off the groin to fluoro. There we go. Okay, so you missed all that. So, okay, so I got basically I use a multi-purpose. I have a regular J up in the pulmonary vein. I'm going to advance my multi-purpose up, and I'm going to switch this out for a Amplatz wire, please. And why don't we open a 10 French gear? I think it goes through a 9, right? So let's just use a 10, okay? I tend to, I don't know, Jackie, if you do this, I just always go, if you're on the upper border or near the upper tolerance of a delivery sheath, I just go to the next size bigger. We're venous after all, right?
That makes sense. Now, are you going to take a picture with your multi-purpose? Just so we can see sort of the alignment of the septum, the plane? Are you going to
I've
inject
never done that
contrast?
before.
Sir.
I've never done that before.
We've never
Should
done
I?
that. Oh, we do it
Yeah.
routinely. But I think it gives us an idea on fluoroscopy, where is your septum, the plane. So if because you have a deficient rim, so the thought is that your aortic rim, or the aortic portion of the left side of disc would flop through into the right side potentially. So it'd be nice to
Right.
know the angulation.
So I'm going to tell you that
Where do you put your
I
eye?
predict.
Where do you put your eye for that?
Yeah,
Which
that's a good
angle?
question.
Yeah, like what typical angles do you get?
Yeah,
to
I
get
usually start with an LAO projection.
just a shallow LAO?
So like LAO 30. Yeah.
Your LAO cranium.
So what I'm also going to do is, once I get an ACT here, with this Amplatz wire, I'm going to also look to see whether I've propped open the septum. I mean, my thought is, I think what I'm going to have to do when I put this in is really clock my sheath aggressively. I'm going to make it so that in the straight AP view, my delivery sheath is parallel to the spine. And I'm hoping that will align the left disc with the plane of the interatrial septum. So this is now with my wire in there. And I know it's not propping open as much as I thought it would. But right about there, you can see how big that gets. So pause that there, Gary. And sort of roll back to where it's open. So you guys open up the 10 French delivery sheath, please. Thank you. I'm going to flush that. No, so Gary, you got to get it when it's at its biggest.
So Matt, with a 24 millimeter device,
Go live.
your left atrial disc is going to be 38 millimeters. Do you have, is that going to be?
I don't think it's going to be a problem. He's a 71-year-old guy. He's got a big, look how that's great. So pause that now,
Yes.
sir. George,
It's really
perfect.
tinted
Now measure
open
from my
pretty
wire
large there.
to the nub of the aortic rim, please. And then I need the dilator, please.
I think it's going to look like a Pac-Man sign embracing the aorta, the anterior port of the aorta, because there's not enough rim there, so it's going to do that.
Yeah, that's correct.
It has a splay.
Yeah, it will split.
Look at
yes,
that,
I
wow.
agree, yeah. So
See,
there is
we're
that
20
fear of erosion as it's, splayed and touching.
So guys, that's 24. You don't see that? That's 24. My face is in the way of the measurement. That's 24.8 right there.
Yeah.
Okay, so let's open up a 24 device, please.
Given this findings currently, I would suggest using a sizing balloon to more
Absolutely.
accurately assess this.
Because it may be larger than that.
Yeah, it may be larger than that, absolutely. And I think, it's better to be cautious and versus pulling out your snare later,
Do you ever use MRI or some other advanced imaging for these to
Yeah,
look at the
we've done-
rims and
yeah.
sizes?
We've done CTA, and I must say, I tell you, we don't see great correlation. I still really rely on balloon sizing at the end of the day for ASDs, yeah, for sure, yeah.
Do you routinely, for the patients who are much older, like this one, do you routinely balloon occlude, find out if there's any change in the diastolic pressure or the pulmonary pressure
That is
before
a
you
good
finally
point.
decide to
Yeah, that's a
close?
good point. I think if the patient comes in here and they have high pulmonary pressures, for instance, then we would consider that. But it's such a small proportion of patients, This gentleman is 71. It's surprising that he actually presented this late. I mean, granted, his ASD, according to TE, wasn't that large, but still, I would have suspected he should have presented much earlier on, so. But in the absence of, say, significant pulmonary hypertension or, shunt that way, I generally don't do balloon occlusion for a long time. Any comments about that?
Was that question for understanding if it's too late to close it or for sizing?
For patients who are much older, so for patients who are much older, who probably are not as symptomatic as what they were if they would otherwise be, you would have cut them younger, we occlude for a while to confirm that since the left ventricle now has a lot more stiffening or whatnot, whether or not they would precipitate diastolic dysfunction or things of that nature. Or if you see a big rise in the PA pressures, then potentially we can treat them with some sort of phosphodiesterase inhibitor for a while and then potentially come back to treat them 3-4 weeks later.
Right. Maybe we can ask the rest of the panel, who, in what situation would you consider doing balloon inflation for long duration and reassess?
I would have used the balloon sizing from the beginning, should probably have shortened the time. But I think the point that Alan is making is very valid. I mean, there's a trial now that is trying to create an ASD for patients with HFpEF, actually, in these patients that might have a lot of heart diastolic dysfunction, hypertension, see what really happens with the EDP, and it might not be unreasonable.
Could you hold that for me? Could you hold me? Yeah, so guys, my qualm with balloon sizing is I think it's going to be very difficult. I could probably make that floppy part quite big if I kept going. It's very hard. I know we do stop color flow, but I still find it challenging. So I think that my, can you hold that for me there? I think that my stiff wire gives me 24. I think I'm going to go in there. I'm going to deploy this or try to deploy this. If I can't catch the aortic rim, I may go to a bigger device.
So which
I'll give a
device
nice
size did you
tug.
choose here now then?
I chose a 24.
You did choose a 24.
That was what I was going in for the beginning, and it seemed like I convinced Ashish to go for a 24. So we'll go ahead and load this up here. So I prepped the device, and now I'm gonna put my sheath into the left atrium. So let's go ahead and set that up. So I'm gonna walk this out, and let's go ahead and load that up once we do. Okay,
So the size 24 was chosen initially based on a diameter that measured 16.8 centimeters, and then
Correct.
a repeat measurement went up to 24.8 and was
yeah, but
standard.
that is, I hear you, Maya, but that's a little bit, that's sort of a gestalt because that's with a stiff wire in there,
Okay.
propping it open. And it's also not incredibly accurate.
I thought the same, but wouldn't that be your equivalent of a balloon sizing? You had the wire propping that open. That's what the balloon size would do, and therefore the balloon size is now 24, and we would normally upsize
20.
based
agree
on
with
that,
Maya there, yeah.
a 26 or
Yeah.
28.
So, I think a 26 or 28 would not be wrong
No,
here, Maya. So,
I'd see
Matthew, we may
28.
disagree with some of what you're doing, but we're really eager to see you try it.
is that
right.
Paul
Let's just
Sorajja?
see
I
whether
haven't
you-
heard you speak.
Yeah.
Paul, congratulations
We
on
don't
a
want
great
a simple
program, by the way.
ASD closure case. We want
Prove us
something
wrong.
interesting. So let's just see what's going to happen. All right.
So I'm just trying to get my delivery sheath across here. Running into my, you guys see the floor? Good, okay. There we go. It's a little bit tight in the skin. I didn't really make that big of a neck there. Okay, good. Add in a little bit more. So we're going to aspirate. Now, you have to always be careful because he's awake. We don't want him to inhale air. So I'm going to put that there. I'm going to set up my ice. You see me well across.
Okay.
Yeah, so we may need a bigger device just to get this to hold. We will find out, though. So what I want you to do, I'm going to clean up my ice. Oh, look at that. Ooh. All right, hold that there for me. And then I'm going to take the device. If you mind, Patrick, bring that device over here. Yeah. Try not to spin the cable. Thank you. Other way around. So, Patrick, when I ask you to, I'm just going to ask you to give me some saline forward. This is ice on the way here.
We're just saying that, Matt, you have 30 minutes, so lots of time. Take your time. Even if it means
Okay.
changing device, too.
I think I might need the 30 minutes. Go. Let's go forward here. With you open? Good. Great. I got that. That's fine. So you can close in and take that off. I'll fix it. You can let that go for now.
Let the ice go?
Yeah. So I'm going to hold this here. I want you to push my cable for me. I'm just going to hold this together. You just push that cable in. Ray is dying to do this case next to me here, but because it's live, I get to do the actual procedure. This is
Can we
my
have
only
one of the
time.
fluoro
Okay.
image up on the screen, please? We're missing a fluoro image.
Yeah, oh my God, no fluoro. Steve, there we go. So why don't we do ice on, you don't need to see, you can see my hands, ice, and fluoro, okay? In fact, good, just like that. You guys like that?
That's great.
Is that AP view?
This is AP. So I'm just gonna push out the left disc and we will assess. What was our ACT, by the way? Was it okay?
303. Yeah.
303, nice. All right, so I'm just gonna push this out. I'm nice and deep in the left atrium, there we go. Okay.
So do you deploy in AP all the time?
Yeah, well, I usually just do it, I mean, I'm doing it by echo mostly, honestly. So I want you to clock this like that, just like that. So you see my issue here is the angle of approach is not quite right.
Yeah, that's
so in the straight AP, what I'm gonna do now is clock everything around. You see how, let's take this off here. How when I clock it, it's gonna get orthogonal as I come down. Wow, this might be a hard one.
Maybe try pointing it towards the left upper pulmonary vein. Get that angle. Yeah, that retroaortic.
So I have
rim
this
is kind of-
sizing balloon to prop it open, but I think we might need a bigger device, guys, I think.
Yeah, I think it definitely does.
Definitely does. It's just really, the problem is that it's just so floppy, it's just not letting me do it. I'm gonna do a little trick here. See if just from here, if I,
Yeah, I think you have a double whammy there, right?
Nope,
Missing the
that's not-
retroaortic rim and the floppy septum.
okay, humor me here. I'm gonna leave this here for a second. Get the sizing balloon for me, please. I need a 8 French sheath. It just seems like it's not going to be able to be long enough to catch the other side. But I'm going to try something real quick. I need a wire to exchange this out.
So Jackie, you described a number
You
of
can let go
different
of this,
techniques for capturing these small aortic
And
rims.
just a sheath wire is
A
fine.
steerable catheter, I don't remember you describing that
Yeah, the
possibility,
steerable
like in a
catheter-
Jollas or something.
Yeah, it wasn't reported, but it would, I think, makes a lot of sense as well. Because what you are trying to achieve here is trying to get your left disc parallel to the
it's all
septum,
flushed.
just so that, you know, at the area where you're missing the rim, it's not going to protrude through.
I'll take the Joao.
And it depends on
That's
where
not- I'll take that.
that missing rim is. So I think the steerable catheter useful. I think again, Gillas might be really
Right,
helpful.
and as I
in
think
that
about it,
position.
marrying that technique with a picture of the septum and plane might be actually quite nice for some of these.
Yeah, that's right. So usually, our usual approach is we get a multi-purpose, get it up into the right upper pulmonary vein and take a cine injection so you can see the plane in LAO 30 view. So that's our framework to start. And then you just angle your sheath accordingly. And then in my talk, I described the other approaches,
No.
which can be a little bit more challenging because it involves deploying some parts of the
just
left
the dilator?
atrial disc,
No, the
say in the
dilator
left
should
upper
do that.
pulmonary
Okay.
vein or the right upper
Have we
pulmonary
missed
vein,
that, please?
depending on where the missing rim is. And that takes a little bit more maneuvering. And then even other approaches such as using a dilator across this
you wanna
hole to sort
use
of
this
prop
different
open your
wire?
left atrial disc so it doesn't slip back.
Yeah, I
But
think
that-
Matthew actually
yeah.
did a case.
Can we grab a
slide
new 8 French sheath?
Previously at the Scripps course,
Scalpel,
where
please.
he had a balloon across to help prop it open.
That's what I'm trying to do right now. If I can get this sheath in the groin here.
Okay. Yeah, so there are
hang
various
on,
different
guys.
advanced
Okay.
techniques to do this, and I think,
They're getting a new one.
one of the other comment too is, ice is great, and but sometimes you might have to default to TEE, for these more challenging cases where you're missing rims, and sometimes it's not just one rim; you might have multiple rims that are
I need
inadequate
to, just give me the,
to do that.
need a multi-purpose.
Any other suggestions from the panel?
The question is
for
whether I should
Matt?
take this out while we're waiting here. I don't want any clots to form. Look at that, it's so close. If I could just get that, I'm gonna show you guys. Multi-purpose and a J-wire. Thank you. And do you think I should just go for a 28 if this doesn't work? If I didn't want to size?
Yeah, I would definitely jump up to a 28 for the next size up to
So let's
try.
let's
But I
get
think
that on the ready.
using a sizing balloon would be a good example here. Any other comments from the panelists and what Matt can do here?
Well, this is exactly why I did this case, honestly.
I wonder if even despite going for a larger device, the maneuvering
So I
of
need
the
to step
device
out,
may
please.
still, he may still
So
need
Maya,
other maneuvers.
yeah.
That's right. He
So,
might need
yeah.
Going from the right upper
additional
pulmonary
maneuvers.
vein.
Yeah, I've never actually, the tiger's leap from the pulmonary vein. I've always tried that. It's never actually worked for me. But I think, Maya, what I'll do is, and I'm going to take your advice. If this doesn't, I'm going to try this really quickly. If it doesn't work, I'm just going to go with the 28 and keep my sizing balloon here. So the next thing is we're going to take this sizing balloon once I get this up. So walk that out for me, sir. You see already what I'm going to do is use that. See how my wire is pushing the catheter up? I'm going to use a balloon to help me with that. I'll take the sizing balloon next with the syringe just on the back.
You're going to take the 10 French sheath out before you do the sizing balloon, right?
No, I actually was ready, and I had another sheath on the side just for this. You asked me if I was going to do some tricks, so I was thinking about this before we
You
even
came
started.
prepared. That's good.
I did. See that?
Good wire.
That wire? Great. All right, so we're going to keep the wire in, guys, okay? So here comes my, can you guys see the sizing balloon on the fluoro screen?
Yep.
So what we're going to do now is, what I want you to do is we're going to go up just a little bit on this. Just so we can see it, just like that. Okay, good. Just like that. I'm going to just hold the catheter for me. Now
Are
what
you
I'm
going
do
to
is
pull out your device first? You're out of 10 French
see,
sheath?
this is,
You going to leave it there?
yes. But I just don't think this is a big enough.
What is the size of your sizing balloon?
So now we'll come down on this. Now you see, we captured it. We got it, right? So the question is, though, is it still too small? Okay. So I'm sorry. I did that so quickly. I forgot to cine that. But so what I did was I had my slightly inflated sizing balloon sort of pushing the left atrial disc away from the aorta. Here it is now. You can see on store fluoro. Thank you. And so my balloon is going up. It then pushes the left atrial disc orthogonally to the aorta. And now I'm just getting it so it's nicely caught there. And then I'm going to deploy the right disc here. And it catches it. And then I deflate the balloon and pull the balloon out. You appreciate that, Jackie?
Yes. This is the alternate technique. I like this
And look at
approach,
that.
but I'm wondering whether you're propping it open with the balloon being inflated. That's might give you a false sense of security, of stability at this point.
Well,
but
look. Well, now, the balloon is out, the wire is out. Okay, so, and now we'll take this back, and now I'm going to give it a nice tug. If it doesn't work, I don't like it, we'll just go back up, and we'll go with the 28, okay? The idea there is, what I did was I changed the angle of approach to grab the aorta. So let's now look at this.
let's see.
So first,
Can you put color on your eyes?
in a second, let me just get the right, so here, I'll get the aorta. Okay, let's color that, please. So there's a little color there, but remember that's the tension. So if I just push my wire
So it's interesting.
Forward a little bit.
It's not wrapping them around the aorta as much as I thought it would.
That's what I'm saying,
Which
it's not
tells me that the
splaying.
posterior side, I think, that dimension is bigger than expected.
well, let me color off this. Well, I'm gonna give you some more pictures here.
But also may mean we're undersizing here and not splaying on the left side adequately. So this would embolize.
There was a little rim.
It was a tiny little rim. What you measured as what, 1 to 2 millimeters on TED?
Exactly. But you know what we're going to do here is you hold that there. But we're going to do, we used to say, oh, don't do such a strong tug. I'm going to be a really strong tug. It is not quite as compressed as I would like it to be. I'm going to cine this here to show you guys. Right? You see that? So you could argue that maybe it's a little flat on the aortic side. This is an LAO view.
Was that your tug? Was that
I'm
a
doing
tug?
a tug right now.
Oh.
That wasn't a tug. That was just
Good, that wasn't a tug.
This is my tug. That's a pretty
That is a
aggressive
good
tug.
tug. That is definitely a good tug. Wow, I'm impressed how stable it looks. I would have anticipated.
So am I.
it to flop back. You're
But look, okay,
yanking
now,
it up, man.
Paul, look at that. What do you think about that?
That's at least 15 pounds of force.
No, but look at that. Look at how I'm hugging the aorta here. Do you like that? Are you feeling better now?
No, I think, Matthew, we're all pretty impressed, I think. I think we can speak for a lot of us up here. It's much more secure. I just said to Jackie I had some concerns about how the aortic side didn't look like it was wrapping around the aortic root as much as I thought it would, but that's okay if it's completely secure.
Let's color that, please.
Yeah, I saw that. Yeah, thank you.
Yeah, that little catheter technique is very helpful.
Yeah. I like your technique, but what I've read was using the balloon sizing on the right atrial side. You actually had it across. You sort of mirroring both using the dilator technique and the balloon sizing technique to sort of prop that open.
Yeah, I guess the dilator the dilator technique is you just take a dilator.
Yeah, to prop it open just
alongside.
like what you did. Just
Yeah.
something a little bit more stiff, just to avoid the left atrial disc from flopping back at the retroaortic rim.
Well, yeah, I kind of developed that just because I had the balloon open one day, and I said, well, I didn't want to wait for a dilator. I was being impatient, or a big catheter, I should say. I didn't use a dilator.
So are you
And
pretty
also, I like the
comfortable?
fact.
Are you pretty comfortable then, you think, based on your tug and your...
Yeah, I don't know. I mean, I'm comfortable. I don't want to oversize this, Remember, I have a 26 in there. Or let's say you do a 28, and my resting defect diameter is 16. That's really, sometimes you have to do that, but it kind of concerns me. Should we do another tug for old time's sake? What do you say?
Sure. Better now than later.
Isn't that really good, guys?
It does look good.
I don't
All
know.
right,
I think
maybe
I'm
we
gonna have
can
to
have a
release
show
this.
of hands on the panel.
Yeah.
And then
the
we're gonna
crowd, too.
and then we're
If
gonna
there's
poll the
there's
audience
anybody
as well.
If there's anyone in the audience, we can poll them.
All right, let's just start with the audience. Who will let this device go? We have, that's it, 10%? Less than 10%. What about the rest of you? What would you suggest? Upsizing? Another 10%? And no comments? Don't know? No. Okay. All right,
How am I going to
about
get a better
panel?
result than this?
How about a panel? Who would let this device go?
I think after the second
2,
tug,
3. I'm tempted to say yes too, because it's pretty easy to retrieve this device. So, and it's kind of fun to do. So if it actually embolize now, it's we got 20 minutes
Awesome.
left for you to.
Yeah, I know, right?
We want you to let it go, just to see what happens.
To quote the Disney song. Ray, what do you think?
I think it looks great.
The fella said let it go so we can blame him.
Did you change the angle of your fluoro? Hold on, the appearance
Yeah,
looks
sure.
different. What did you go to? What angle are you at now?
That was 40
Okay.
LAO. I mean, that is this is 30 LAO. It looks really good, guys. I can always retrieve it.
Yeah.
You guys have the snare cart in the room? You always just say that. And then it usually works. Okay, so I'm going to release this.
All right.
And Jackie, you're the one who recommended me to release it, so I'll let you know, okay? I always
okay,
tell
you
the
can bring it
fellow
up, me.
that it may move quite a bit when we release it from the tension, and so you'll gasp, and then you take a breath because everything's fine. So I'm counterclocking this here. I'm just going to move this up a little bit. There we go. Oh, there we go. Hey, see it moved?
Yeah.
But it's because it's a floppy septum.
Yeah, it's staying in place. All right.
That's pretty stable. He's snoring now, by the way. And now,
Well, the transthoracic echo
Color
tomorrow
off,
will be
please.
very important, because if we were to see, some of the embolization can occur in the first 24 hours as well.
maybe we should ask this patient
Stop
to not be
talking
doing
like
a lot
that.
of sports in the next 1 month or lifting heavy objects. I had a patient who decided to move his house, and when we moved to another house and moved the entire furniture himself, and the device moved a little bit. A very young guy. So
Well, I'll tell you, he is really snoring now, so that's the Mueller phenomenon, as opposed to the Valsalva, by the way. That's the opposite of Valsalva. So when you snore, let's see, you are inspiring against a closed epiglottis, and you can see you get a lot of motion of the interatrial septum when you snore, right? So, and it's hanging in there. So this is actually a pretty good stress test on our position. And it's hard to get the aorta in short axis because the Septum so floppy, it's shifted the device a bit on to get so it's not so it looks like it's on FOSS. You appreciate that? But this is just great. So let's color that there. You saw it for a moment. It's nicely catching the aorta. On the aortic side, please. Yeah, there's no leak there, guys. This is great.
That is good. I mean, one advantage of not going larger is
Save that,
lower
please.
risk of erosion. Right?
Oh yeah,
so
for sure.
I think
for
that
sure.
is that's a good example. Thank you.
All right.
Showing us how it's done.
Very nice.
Thank you guys so much.
Congratulations. Thank you.
Thank you.
Beautiful case.
You can put the snare card away. Okay, so that's. Jackie and Paul, I want to thank you for the invitation to do these cases. It was a lot of fun. Hopefully you'll invite me back next year. I want to thank the staff here and for getting these cases on time and setting them perfectly. Went back and forth incredibly smoothly. So thank you all. Leslie, I didn't see you at the beginning of the case, so thank you back there, our nurse. And Jackie and Paul, I hope to see you guys soon. And thanks everyone for coming to the conference. We're going to finish a little bit early. Is that okay, Jackie?
Thank you. Yes. Perfect. Thank you
All
very
right,
much.
great.
Beautiful
Thank you.
example. We've learned a few things, and thank you to the panel and the audience for staying. Thank you so much.
Thank you.